Hello, this is Michael Altos, and today we're talking about psychiatric and central nervous system drugs, and this is part 1. We're going to start with talking about antidepressant medications, and we'll start with the far and away the most common class of drugs, which are the SSRIs, the selective serotonin reuptake inhibitors. Obviously, we're starting to talk about drugs that we don't administer, but rather drugs that our patients are on and have been taking prior to the perioperative period. SSRIs are the most broadly prescribed class of antidepressants, and they're used not only for depression, but for panic disorder, for obsessive-compulsive syndrome, for social phobias, and post-traumatic stress disorder. So you may see these drugs in a wide variety of different patients. Some of the names that you might encounter, and as always, this is not something I would test you on, but so you can start to become familiar with some of the generic and brand names. So these include fluoxetine, which is Prozac, sertraline, which is Zoloft, paroxetine, which is Paxil, citalopram, which is Celexa, and escitalopram, which is Lexapro. And all of these drugs work in a similar way, which is by increasing the amount of serotonin in the synapse, and they do that by blocking reuptake of serotonin, thus the name. Now, SSRIs have certain side effects. They include insomnia. People can occasionally become agitated. They can complain of headaches, nausea, or GI upset like diarrhea. Sexual dysfunction is a common complaint in these patients, and occasionally we see platelet dysfunction as well. The SSRIs are metabolized in the liver by cytochrome P450, and fluoxetine especially is metabolized in this way. So we can see some competition for the P450 system in these cases. So perhaps patients could have increased levels of TCAS if they're taking those, or some of the other neuroleptic agents. Patients could theoretically have arrhythmias if they're taking metoprolol. I can't say that these are really very common. We have an awful lot of patients who take SSRIs, and these sorts of side effects or interactions are pretty uncommon. You should definitely be aware of the potential for serotonin syndrome. Since these patients are not having normal reuptake of serotonin, there is some risk that they can have an increased serum levels of serotonin. Again, this isn't something we see very often, but it's definitely something you should be aware of. So patients can develop serotonin syndrome with symptoms like anxiety, restlessness, insomnia, and this is especially common when they take other drugs that also inhibit the reuptake of serotonin. Those might include monoamine oxidase inhibitors, which we'll speak about later, carbamazepine, which is a certain kind of anti-epileptic drug, or linezolid, which is a certain antibiotic. The nice things about SSRIs is that they're not usually lethal if you overdose, and since we're dealing with a patient population who may be at some risk for harming themselves, it's good to be able to give them a 30 or a 90-day supply of something that, if they take the whole bottle, is unlikely to kill them. There are many other antidepressants that are related to SSRIs, and they inhibit reuptake of other neurotransmitters like dopamine or norepinephrine. So, for example, venlafaxine, which is Effexor, is an example of one of these SNRIs. It blocks the uptake of norepinephrine as well as serotonin. And it has less anticholinergic effect, less of the dry mouth, less hypotension. And then bupropion, which is also known as Wellbutrin or Zyban, is nice because it has less sexual dysfunction, less hypotension. It's been used in other indications like for smoking cessation. That's all there is really to say about SSRIs. Take a moment to see if you have any questions, and then we'll move on. Now the TCAs, the tricyclic antidepressants, the most common names that you may hear are amitriptyline or nortriptyline, imipramine. Elavil is a common brand name for amitriptyline. And these drugs block reuptake of norepinephrine, and they may block some serotonin as well. Most of the time, if you see people taking these drugs today, it's going to be at very low doses for chronic pain syndromes, not really so much for depression. These drugs are very strongly bound to plasma proteins, and they are hepatically metabolized. So we always want to be careful for drug interactions, especially when we're dealing with other drugs that also bind significantly to protein. TCAs are very effective antidepressants, and they've been around for a long time, but unfortunately their side effect profile was really not well tolerated. So the anticholinergic side effects, the dry mouth, the tachycardia, even some urinary retention, these were really significant side effects for people. They developed a lot of orthostatic hypotension and even some arrhythmias due to prolongation of their PR interval. People became a little bit sedated. They had a lowered seizure threshold. And most significantly was that the gap between the safe and the lethal dose of these drugs is very narrow. And these drugs are actually lethal in overdose, causing myocardial depression and all sorts of ventricular dysrhythmias. So we don't see people taking TCAs very much anymore, except, like we said, at low doses for chronic pain syndromes. As far as drug interactions, these mostly fall under the category of the anticholinergic effects and the fact that these drugs block the uptake of catecholamines. So, for example, sympathomimetic drugs, any drug that causes a sympathetic response, may see an exaggerated response in these patients because they've already blocked norepinephrine uptake. And we especially want to consider avoiding indirect acting agents like ephedrine. Now, the only thing to be aware of is if someone's chronically taking TCAs, and so they have increased levels of norepinephrine, they may actually develop sort of like a lower sensitivity to catecholamines as a result of being exposed to all of the norepinephrine. So we have seen people have both attenuated and exaggerated responses. Atropine, with its anticholinergic effect, may have synergy together with the anticholinergic effect of the TCA, and patients may have increased likelihood of postoperative delirium. There's also some studies that say there may be potentiation of opioid and barbiturate effects with the sedation that you would see as a result of that. Having talked about TCAs, we're now going to move on to another kind of antidepressant that isn't used very commonly anymore, and those are MAO inhibitors, monoamine oxidase inhibitors. The most common of these drugs is phenelzine, which is still not a very common drug. Others that you may never hear of, except maybe selegiline, which we'll come back to in a few minutes. These are very effective drugs for depression and anxiety. Again, highly effective. But as we'll see, their side effects preclude them from being used anymore very commonly. MAO, monoamine oxidase, is an enzyme which metabolizes catecholamines, which are monoamines. This includes dopamine, serotonin, epinephrine, and norepinephrine. And it comes in two subtypes. There's the MAOA and the MAOB subtype. MAOA is the one that does most of the catecholamine metabolism. And that, together with another enzyme called COMT, they create the vanillomanilic acid, the VMA that we've talked about, which is a metabolite that we see in the urine of patients with pheochromocytoma. There's also the MAOB subtype of the monoamine oxidase, and it's mostly involved in the metabolism of tyramine. Now, most of the MAO inhibitors are irreversible non-selective inhibitors. That is, they inhibit both MAOA and MAOB. So these drugs, although very effective, are not used anymore because of their side effects. Once again, the orthostatic hypotension, the anticholinergic side effects, and the sedation. People had sexual dysfunction and weight gain. And also, there was the need for a tyramine-free diet. The tyramine is normally deaminated in the liver by MAOA and a little bit by MAOB. The tyramine builds up as a result of this inhibition, and it actually causes a sympathomimetic response. It's kind of like having a pheo. And in order to prevent this, and it would cause a hypertensive crisis and things like that. So to avoid that, people have to avoid foods that contain high levels of tyramine. And these include avocados, cheese, liver, fava beans, and Chianti wine. Now, MAOB inhibitors like selegiline actually don't carry any dietary restrictions unless people are taking very high doses. So even though these are pretty much exclusively tyramine enzymes, these MAOB subtypes enzymes, patients seem to do okay on a normal diet. Once again, like the TCAs, the overdose of MAOIs is lethal, causing all sorts of problems with tachycardias, hypermetabolism leading to hyperthermia, seizures, and even coma. Now, an important point here is, for many, many years, the teaching was to stop MAOI drugs 2 to 3 weeks prior to anesthesia because of this risk of sympathomimetic crisis, this risk of hypertensive crisis. And there is absolutely no data to support this. And I have seen board questions now that test this, expecting you to know that you should not stop these drugs before anesthesia anymore. Again, I'm not sure how practically important this is because we don't see a lot of patients taking these drugs. But at any rate, if you do see a patient taking them, they can proceed to anesthesia, and we may want to consider avoiding indirect acting sympathomimetics like ephedrine in favor of direct acting drugs like phenylephrine. Some people would also avoid epinephrine when possible, like in local or regional anesthetics. Some people have described interaction with opioids like meperidine, which can lead to a variety of responses, including excitatory and depressive reactions. So that covers all of the antidepressants. We're going to stop here, and if you have questions, please let me know. And we can be in touch and talk about them in class, and then we'll pick up with part 2 in the next video.